Hello and welcome to everybody who's attending today. My name's Coletta Dorado. I'm the founder and CEO of AZZLY. And thank you for joining us. We're really excited about this session as we introduce AZZLY's new treatment plan feature. At AZZLY, we're deeply committed to supporting mental health and addiction treatment centers with innovative solutions that improve efficiency and patient outcomes and allows for a whole care team approach. Our newest master treatment plan module not only streamlines your workflow, but also aligns with the highest standards set by the Joint Commission and CARF, which is why we have Peggy Lavin, who's joining us today. She's an LCSW and Director of Behavioral Health for Accreditation Gurus. I met Peggy many years ago at the Joint Commission, and we really value her insight and her teams. They have representatives all throughout the country that help behavioral health as well as other facilities in their accreditation needs. She's going to provide insights into treatment planning standards, and Maria Gray also is joining us. She is an LPN, AZZLY's product manager and senior implementation specialist, who will walk you through how this feature works in action. So we're going to keep this tight, around 30 to 40 minutes. We've received many questions from the attendees in advance. We're going to get through a group of them, but we'll be sure to answer them through email or correspondence from our team. So our goal today is to equip you with the knowledge and tools to take your treatment planning to the next level, creating a seamless and collaborative care experience for your staff and those that you serve. So let's begin. We're going to start with myself and Peggy, and then we're going to move on to Maria. Peggy, so what are some of the current treatment planning standards that the accreditation agency have mandated?
Well, first, thank you for asking me to join today's webinar. Always happy to talk about accreditation. Your question, current treatment planning standards mandated by accrediting bodies such as the Joint Commission, CARF International, and also good practices such as ASAM criteria consistently emphasize that a treatment plan needs to be individualized and person-centered, patient-centered. That means the plan needs to reflect information and planning specific to each person served. The current standards also mandate that the person served needs to participate in their entire treatment experience: assessment, treatment planning review, discharge planning. Accreditation standards provide a framework for a treatment plan, and there are required components. Needs, what are the issues that's preventing a person from reaching their desired functioning? Each identified need needs a goal, and a goal is a high-level outcome, treatment outcome. Because it's high level, the standards require that each goal be broken down into objectives, and they require that the objectives be measurable, that they be indicators of progress, and that there be an anticipated time frame for the person to achieve their goal. Another required component and an important component is a listing of interventions and services. So this is any and all activities, actions provided by the organization in which the person will participate to reach their goal. Individual, family, group therapy, if it's medication-assisted treatment, the prescription administration of medication. The standards also require that the interventions and services identify the frequency of each activity and action. I would mention that the standards require that the plan is relevant at all times. So it always has to reflect the current circumstances and conditions of the person. There's the initial treatment plan, and then as it's implemented, the treatment plan needs to indicate the person's response to treatment, their progress. Joint Commission has a standard that says the use of a standardized tool or instrument to monitor the person's progress in achieving their goals must be used. So if it has to do with depression, some standardized instrument that measures what is the level of depression at the beginning of treatment and how treatment impacts that measurement. And finally, I would say the treatment plan needs to clearly indicate that the person served has participated in the planning and is in agreement with the plan. Clear indicator.
Great. Well, that's quite a bit that you covered, Peggy. And one of the ones that you mentioned, and we get a lot of questions on, and there were questions that came in, was in regard to assessments, which you mentioned, and being a critical piece of effective care. Why are these tools being highlighted so prominently in the current standards? Is this a change, or is this something that has been evolving?
I would say it's been evolving. Accreditation standards have always required that treatment plans be based on assessment findings. So that process is a very critical component to effective care. A comprehensive assessment will accurately identify the needs of the person served. And it's been evolving in the sense that are emphasizing, and one example is more the participation of the person served. So and they're using adjectives like active, collaborative participation, which, action type adjectives. And in the assessment process, that is shown by the person being actively and collaboratively involved in identifying their own needs and also their strengths, their abilities, their preferences. And that information, as well as other assessment findings, need to be reflected in the treatment plan. Evolving because CARF and Joint Commission, the accrediting bodies, are looking for outcome measurement. It's how effective is this treatment? As I mentioned, the Joint Commission is even asking that a standardized tool be used to measure the effectiveness of each person's progress in treatment.
Great. Thank you, Peggy, on that. So
You're
let's
welcome.
talk a little bit deeper about the master treatment plans and engaging a care team, as you mentioned, and who needs to be engaged. What are the expectations?
Well, the simple answer, Coletta, is that everyone involved in the treatment process and the treatment review process needs to be involved. Everyone that's providing assessment, interventions, and services. You asked who needs to be involved. So it does depend on the level of care. So if you have a person who's going maybe twice a month for outpatient counseling, there's the counselor, there's the therapist. But once you go into more intensive levels of care, the numbers start increasing. So you may have multiple counselors or therapists doing individual, family, group therapy. You may have someone involved in like in a residential level of care, the physical health care needs of the person. If it's medication-assisted treatment, someone prescribing, administering medication. Residential may have a dietitian. The standards say that when there is more than one, that they're all working together, that they're communicating, they're collaborating, they're coordinating treatment. Remember, it's person-centered, so everything needs to be directed directly to the person served.
Towards the individual. Okay, makes sense. Peggy, standards seem to place a strong emphasis on that patient collaboration component you mentioned. Can you share more about how treatment planning has shifted to include the patient more actively in this process?
Yeah. Well, that's exactly right. The active and collaborative participation is emphasized by the accrediting bodies for sure, Coletta. I've mentioned the type of participation in the assessment process. I gave 2 examples. In the treatment process, the standards say, and this shows the participation, that the person's own words and ideas need to formulate the goals and objectives. CARF has a standard that if there is a need for a more clinical goal, okay, but it has to be understandable to the person served. So people need to watch what clinical terminology they're using. It has to be very understandable to anyone reading the treatment plan, but most importantly to the person that is being served, the individual served.
Interesting.
Yeah.
That is very interesting, and it certainly makes sense. So for centers aiming to implement these standards successfully, challenges are bound to arise, right, Peggy?
Yes.
What are some of the common obstacles and what advice would you give to help centers overcome them, if you can think of any?
Well, I have thought about this and also asked our consultants, and some of what they see when they're working with organizations to prepare for accreditation or reaccreditation. One is that people seem to be challenged with the measurability of the objectives, and that is a requirement. So perhaps an example might illustrate that well. The goal may be sobriety. A measurable objective might be the person identifies 2 or 3 triggers that lead them to drink or use drugs. Another example, a person identifies 2 coping skills that they can start using to when they're triggered or to prevent a trigger. Might be a coping skill that's worked well for them in the past. It might be coping skill that they learn in an individual or group sessions provided by the provider. So measurability is a challenge at times. Another example that we see is and I think I mentioned, the treatment plan has to be reviewed periodically and it has to stay current. And organizations seem to do very well in the periodic reviews. So they have an initial treatment plan and maybe their policy says every month or every other month for a halfway house, they're reviewing the treatment plan and they're doing pretty well at that. That's happening pretty well, it's scheduled. But sometimes our consultants are seeing in progress notes that there has been a rather significant change in condition or circumstances of the person, and it's not considered in the treatment planning review. There's not a treatment plan review to say, okay, this might mean a different need. It might mean that the treatment plan needs to be changed, because it always has to reflect the current condition and circumstances of the person. And the last challenge I would mention that our consultants see is that I said in the assessment process, there's an identification of needs by the individual and by help with the provider. And all of those needs are expected to have a goal. But sometimes we're seeing that there's a missing need, a missing goal. And that can't happen. All the needs have to be mentioned or addressed. But it could be that that need is being referred to an external provider for treatment during that episode or after discharge. Perfectly okay, but it needs to say that in the plan. It can't be missing. It needs to state this is being referred. So those are some of the challenges I thought about and thought worth mentioning today.
No, that's great, Peggy. And it all circles completely around to that entire care team approach.
Yes.
Making sure that you've got the whole team involved. So as your example highly emphasized, if a clinician is seeing something and is documented in a progress note, something that's changed, having them part of that care team and having that ability to, in a review, have them share that so a treatment plan can be updated. Invaluable. And it really makes sense, the evolution towards a whole care team approach, not just one individual taking care of it. I think it's great. And thank you for those insights, Peggy, and updated standards. I'm sure there's more to come. And, emphasizing, as your team does, on that patient-centered, the outcome-driven care. It's clear that these standards are not just for compliance. It's really about delivering a better outcome for the individuals.
Exactly, Coletta. Individualization and engagement of the patient, the person served, means they'll be more engaged, they'll have more ownership of their treatment, and that contributes to better clinical outcomes.
Yeah, it's wonderful. I mean, we have seen with the many facilities that we serve, the evidence-based assessments that they're discovering, that are research-based, that they want to utilize, whether they're serving youth, whether they're serving substance use disorder or mental health. There really are some wonderful evidence-based assessments out there and standards, many of them very common, and many are using the same ones, but other ones that are being utilized as well. So It's great
And
to see.
evidence-based interventions and services.
Yeah, there you
Again,
go. There you
hand in
go.
hand with assessment.
Yeah, of great value for sure. So we've received many questions, as I mentioned, from attendees in advance, and Peggy, you've addressed a lot of them
Oh,
in
good.
in your presentation. So thank you so much. And as time allows, we'll have some questions at the end. So appreciate your staying on board, watching the demo, and then we'll get to some Q&A at the end. So now we want to show you how AZZLY is helping treatment centers meet these standards with ease. I'm going to hand this over to Maria Gray. Maria is our product manager and a senior implementation specialist. Maria is superb and a great listener. She brings many comments, many suggestions, recommendations, feedback from our clinical and medical and those that we serve back to AZZLY, back to our development team, so that we can keep getting better and better. So I want to thank all those that are attending that are AZZLY users. You've been engaged, and I know Maria has touched many of you to bring you in on some beta testing and some sneak previews on this master treatment plan. And we really appreciate your feedback, invaluable for our success and for our successfully serving you. So Maria, I am going to have you take it away.
Thank you, Coletta. I will say Coletta has taught me to be a better listener over the years. Coming in as a nurse within this industry for many years, I did think I know a lot, but I have learned so much from many of you and the experiences that you all have shared as well. I do very much value the patient-centered approach. I feel that clients can spot a textbook approach a mile away. So with the new direction of making it, not making, but gearing all of the treatment plans, their notes, their plan of care towards them, allows them to be in control of their recovery and much more open to following what is the approaches that are offered. So within AZZLY, the Master Treatment Plan tab that is now available for any of you who would like to use it. It's available within the tab, as you can see on the patient list. It is also available within the e-chart. You also have the ability to add it to your encounters. So the Master Treatment Plan screen, the primary difference, the first primary difference between this and our other master treatment plans is that this is a living document. So instead of creating a treatment plan, finalizing and signing it, and then sending alerts to others who may need to sign it, and then later opening another version and importing the most recent data and updating it, this will remain a living document. It can be updated as needed by any members of the care team, and allows the most current version, the most current data to always be available. As Peggy was mentioning, that it always needs to be the most current information about that patient's progress that is being addressed. So this screen will allow for that. So at the top of the screen, you will see an area labeled treatment plan. And within this drop down, now this being an environment that we have created several in, you may see that we have several treatment plans created for this particular patient. I'm going to focus on the one at the bottom, but you do have the option to create a treatment plan at any point. Typically, those who have been using this feature are creating a treatment plan based off of a patient's episode of care. Not necessarily a medical treatment plan and a mental health treatment plan and so on, but just based off of an episode of care, because multiple areas or specialties within a facility are able to all document in this, making sure that all are aware of the patient's overall picture, instead of having separate treatment plans. Once a treatment plan is created, it will need to be initialized, which I have already initialized this one. So it is in progress, and it will stay in progress until either all of the needs have been met or until the patient discharges, which hopefully coincide with each other. So it will not be finalized until the patient is discharging typically. At the top, you will see a list of the patient's diagnoses. And this will come into play again as we move forward, but you will have available a list of their diagnoses to reference. You will also see any risks or precautions that may be referenced for this patient, as well as archived versions, which we'll talk about again as we move forward. The first banner that you see as we move into the actual treatment plan is the patient assessment. Peggy placed heavy emphasis on this, rightfully so. This is where we're going to identify the patient's strengths, their preferences, and abilities. This is also where we will document any outcome measurement tools or assessments that have been used. So if I were to select yes for this question, then it will allow me to document the results of those outcome measurements. So if I had any GAD-7 or PHQ-9 results that I would like to expound upon, then I can update those within this section and then click Save. Below that, you'll see a section where it's labeled Needs to be Addressed. As Peggy mentioned, we have moved away from the term problem to need. So think where you previously may have had a list of problems, this is now your set of needs. I have some needs already created for this particular patient. If I needed to create a new need, I could do so simply by clicking the Add Need button over on the right. I do want to point out that it says Select Template. When I click on this option, it offers me the primary option of default, which is a blank format to work off of. And we also have a few additional needs or templates that have also been added. So relapse prevention or substance use disorder. If I were to select any of these, let's say substance use disorder, then it will automatically fill in, and I will detail this as we move forward, the need as well as any goals, objectives, or interventions that I have as a user or super user have had the opportunity to lay out. So if you would like to pre-format some goals, objectives, and interventions for your organization, you do have the ability to do so. If you choose to use that, then your users may modify those so that they are detailed for that individual patient at any point. So I just want to mention that that is an option. But for the needs that I've already listed, I'm going to work off of the relapse prevention need at this time. Within this need, you'll see, or within any of the needs, you'll see some statuses listed. If you see a number out to the side, that's referring to the ASAM dimension that is being referenced. So if your organization does use ASAM, then you may elect to have the ASAM dimension listed or identified within your need. If your organization does not use ASAM, then we can hide this option so that it does not display for you. Now, I have already, as you can see, updated this or created this need. However, at any point, I can click the pencil icon out to the right and update as needed. So if I needed to, at some point, refer to external resources, I am able to document within a text box which resources I may be referring to. I can also update the status at any point as needed. And then here is also where the dimension is able to be selected. Now, because I am on the relapse prevention need, as I scroll down the screen, you'll see the option for goal, and you only see one goal listed. And as I click on that goal, you'll see a tree begin to be built so you'll see the relapse prevention need, with an arrow identifying the goal. So you know that these two are connected. So because I have selected this need above, only the goals for that particular need are listed below. If I had selected a different need above, then I would see different goals listed below. Again, I do have the ability to click the pencil and edit at any point. Now, with any of these sections, as I edit or update, you'll notice a sign button out to the right. When you update a section, you may choose to sign either by staff signature and or by patient signature. So if I were to update this goal, then I can choose to click sign and apply my staff signature. I can also allow the patient to sign by entering a 4-digit PIN here, at which point it would display their participation statement and then their signature below that, indicating that they have also signed that section and the updates applied. Many of these sections also contain a comments area. So as you update, if you would like to add any comments, maybe some changes that were made or some recommendations, if you're part of an interdisciplinary team, you do have the ability to add additional comments here. So know that that is available. As I move down, because I am on this specific goal, and of course I could add goals if I would like, but because I'm on this specific goal, as I move down the screen, you will see objectives related to that goal. So by clicking on an objective, again, this tree continues to display, allowing the user to remember which need they are on, which goal is being addressed, and then again, which objective they're updating. Okay. Same applies, I can update at any point. Of course, as Peggy mentioned, it's important to document the progress or lack of progress towards an objective throughout the course of treatment. So this is something important that can and should be updated as a client progresses. And then based on the objective that I have selected, as I scroll down, I will then see any relevant interventions. If I were to select a different objective, I will then see interventions related to that objective. Okay. So as I move down, I have the ability to sign as needed. Now, when we get down to the interventions, I know that Peggy did mention that it is, of course, important to document the frequency, that it's timely, what clinical process or what services are being offered. So by clicking the pencil icon, I do have the ability to document, of course, a frequency or an amount, I apologize, as well as a frequency, and then a clinical process. Now, you do see here a set of clinical processes that are defaulted within our system at this time. However, you may at any point select the option of other and enter your own clinical process. So if I wanted to change this, for example, to say case management, I could certainly do so and then update. Now, this is only one part of this feature. Some additional portions of this feature that I would like to point out are the MTP logs screen, or is one of the screens I'd like to point out is the MTP log screen. This is an area that supervisors in particular will find useful. You have multiple filters that you can choose from here so that you can view any changes that have been made to any treatment plans. If you would like to filter by date, only to see those treatment plans that have been updated maybe within the last week or the last month, you could certainly do so. You can also choose to filter by status if you want to view only those that are in progress or those that are finalized, those that have been edited or that someone has signed. You do have many filter options so that at a glance, you're able to view the modifications made to filter or made to treatment plans at any time. You may also filter by patient. Maybe you want to view only by those changes that a certain staff member has made or by a specific type of treatment plan. Now, I mentioned earlier the ability to configure your own preset needs, goals, objectives, and interventions. With a privilege, then you may, under configuration, view the master treatment plan configuration screen. And within this screen, I believe that most any need by any organization, whether you're serving substance use, mental health, adults, adolescents, any services at all provided can be met, because within this screen, you have the ability to completely modify how your master treatment plans display. Not only can you modify the preset text, so for example, if I wanted to change the name, change the field as evidenced by, I'm just going to change it to evidenced by, for example, then I could. But I could also change the name of the field. I could choose to delete that field and create a new field. When creating a field, you are able to choose the name of the field, the type, so whether it's a single line text field, a multi-line text box, a single select drop down, a multi-select drop down, or a date picker. You also have the ability to allow conditional fields so that certain fields only display based upon the answers provided within other fields. You are able to add as many fields as you would like, as well as modify existing fields. So you can truly build your treatment plans to meet the needs, not only of your organization, but also by your state. So if your state requires certain date fields within certain fields, you're able to easily add those fields. You're able to add preset, as I mentioned, goals, objectives, and needs. You can build these out in as much detail as you would like. And again, once these are created, your staff will have the ability to still modify any of those preset treatment plans so that they are still personalized to the actual patient being served. So at this point, and one last thing I do want to mention, because for those of you who have been with us for a while, you may know that previously, in order for anything to be printed, it must be finalized. With this treatment plan screen, you will see a printer icon in the upper left corner. You may choose to click print, and at any point, whether it's finalized or not, and you could choose to print the entire treatment plan, or if you would like for your patient to only focus on specific goals or interventions at a particular time, then you may choose to only print those areas. So you have some flexibility in terms of printing, whether printing the entire treatment plan, maybe to send to a payer, or selecting only specific focus areas for your patient. You have flexibility there. So at this point, I would like to turn it back over to Coletta or to those who have joined for any questions that you may have.
Maria, thank you. Peggy, if you would rejoin as well. Thank you so much. Maria, I think you hit upon some key items that I know many of our existing users may have some questions. We're not taking away how the master treatment plans and the plans and the forms and the work we do on your behalf as far as creating. We're not removing that functionality or feature at all. But we have listened and we have heard many of you want to do your own configuration. Many of you want that power. And because you've been with us as long as you have, you realize how to do it. You've learned how to do it. You know how to do it. So allowing you the ability to configure is something that we're real pleased to be able to offer you. As Maria mentioned, the configuration is authorized user. You have to have permissions, privilege. It isn't open for a free-for-all for any staff member to make changes. It will be controlled by you. But the ability to configure it, all that you're seeing today exists. This is in production, as Maria mentioned. If you have interest and you want to configure, if you want to get this master treatment plan tab available, it can be available today. Just submit your request to clientservices@AZZLY.com. The team has also written up instructions and a guide for the master treatment plan. It does exist in e-learning, and they can send a macro out if you do put a ticket in as well. They can get you out. So Maria, again, thank you so much. Great job. Very thorough. I think, you know, based on hearing Peggy and then you're demonstrating, you know, we really listen to healthcare professionals as well as our users. There's so many audits that take place at every state level through the accreditation agencies and others, that this really was a joint effort in making sure that compliance is met. I mean, healthcare is all about compliance. And when you get an audit, you want to make sure that you can show them. I'm thrilled with the audit log that's been created, because I think if you show that to any auditor, they've got to be impressed. if you've done it, if you have indeed reviewed and documented, they'd have to be impressed with the attention to detail in the reviews that you do. So I'm really excited. Peggy, one of the first questions was in regard to increased compliance and personalizing those treatment plans. You know, if you want to summarize, you really hit upon it, you know, earlier on the entire care team and engaging the patient, I think.
Sure. So some of the suggested ways to increase compliance, well, let me start with personalizing the plan. I hope I've emphasized that the active and collaborative participation of the person served throughout their experience is critical, and will certainly personalize a plan. I gave some examples how to do that in the assessment process, how to do that in the treatment planning process. I would also say make sure that your procedures and protocols regarding treatment planning cover the applicable treatment planning standards, that your staff know your approved protocols and procedures, and they're using them, and that you're getting the results that you intended. You mentioned, Coletta, and this is excellent, evidence-based tools during the assessment process and during the treatment process certainly increase compliance. And because you're monitoring an individual's progress, it adds to the individualization of the plan. And as Maria just demonstrated, leverage technology to assist you for efficiency and compliance. Sometimes the people doing the interventions say, I don't have time. So you have to leverage technology to assist them to be efficient with their time. So those are some of the suggestions I would have.
Great. Thank you, Peggy.
Mhm.
Maria, you mentioned terminology, interdisciplinary team, IDT, that meeting approach, and I think Peggy with the whole care team approach as well. The master treatment plan seems to allow for that seamless collaboration. Now, what if they have an external provider? And I think, Peggy, you mentioned there are some external providers or consultants. If they were authorized to access AZZLY, could they document in this master treatment plan as well, if they were to use an external provider?
They would actually have the flexibility of either situation, Coletta. So if the external provider were authorized to view the entire treatment plan, to view all needs, then they would absolutely be able to. However, they would also be able to create their own treatment plan if needed for that for that external provider, so that if that external provider needed to create their own set of needs and goals for that patient, then they would be able to do so as well.
Okay, great. Peggy, you made mention of, I think, living document and the importance of a living document to treat an individual during their episode of care. How important is that quote unquote living document?
Well, if you want to be in compliance with accreditation standards, it's critical. You can't create a treatment plan after the assessment and then let it stand without any changes or updating or revision for the whole treatment episode, because it's required that it reflects the current circumstances and conditions, and it has to, at a minimum, show the response and progress of a person. So even if there's no significant changes in condition or circumstances, there is either progress or lack of progress, as Marie mentioned. So it's a living document. It's a real-time document. It just isn't a stagnant initial treatment plan that sits there. It's got to be relevant, and it's got to maintain relevancy to the current condition and circumstances.
Peggy, this one's in regard to the differences between goals, objectives, and needs. Can you distinguish those?
Sure. I think I mentioned this a little bit when I was talking. Needs are the issues that's preventing the person from achieving their desired functioning. So it could be, I'm drinking too much. I have problems with relationships, family relationships, significant others. And I don't want to be like that. I want to have friends. I want to have a girlfriend. I want to have a job. I want my family to invite me to Thanksgiving dinner. So needs are, what the person identifies as the reasons for seeking treatment. Goals are very broad, high level, and Maria has done a great job at showing us some that she's put into the system. Very high level, and because they're high level outcomes, a treatment plan should give the person specific steps to take to reach that goal. So the objectives break down the goal into specific steps. And I gave you an example. I hope that was helpful. And I did state, and I want to emphasize this, interventions and services, it's any and all intervention and services. So if the person has some kind of physical health need, and their blood pressure is going to be monitored daily. If they have some type of special dietary need, and I'm using non-behavioral healthcare examples because sometimes the organizations are doing a great job with the behavioral healthcare needs, goals, objectives, interventions, but not putting in the other activities and actions that they're taking in regards to the person, particularly their physical health needs.
Okay, great. Thank you, Peggy. Great detail. Maria, and I think you might have covered this. Can the treatment plan be used in youth treatment programs as well as adult programs?
Absolutely. The ability to configure the treatment plan based on the configuration screen and creating your own fields allows for as much flexibility as you would like for any type of service that's being provided for any age group, but also the standard treatment plan that exists does contain fields that would apply to adults as well as adolescents.
Great. Thank you, Maria. I'm going to grab this one. How intuitive is this program for intensive outpatient client billing? We're really excited about the fact that AZZLY is an all-in-one. So from the clinical perspective, if you didn't document, it didn't happen, and therefore you can't bill. We've put a lot of business rules in play based on your program's business rule, period. In other words, if you don't bill unless everything's been signed off, finalized, then we have auto billing available, works very efficiently, but there can be a stop in place that if a document is not signed, it will not go to the billing group. And I think that's really important because you've got to have control. You have to have compliance. There's accountability that has to take place so that when an audit comes along, you're not going to get in trouble for something that is preventable. So we're advocates of trying to prevent things from happening that technology, as you said, Peggy, can prevent. And so our auto billing is very efficient, whether it's based on calendared appointments in your charge master and fee schedule, or if it's based on encounters in what has to be done for that particular encounter. And as Maria mentioned, the master treatment plan can be included in that. We also added this year required encounters. So we are trying to use technology for your benefit and to keep you compliant and help you get paid for the services that you offered, because we need more of you out there. And I know it isn't always easy. So we're bucking up on our 1:45. We only have a couple more minutes. And also on the RCM side, we're going to do a webinar in March. But if you are interested in the billing side of AZZLY, please request access and go into the e-learning. We've got a lot of demos. We've got a lot of presentations on the billing side that might be helpful. Can the plan of care form be organized so problem areas and goals appear in a manner similar to the way they appear in the progress note? Maria, maybe that's for you.
They absolutely can. We are always able to configure your progress notes and connect the treatment plans within an encounter so that you're able to coordinate those to complete your documentation. Absolutely.
Okay. Wonderful. Great. Well, with that, we got 1 minute. I just wanted to thank Peggy and Maria for attending. Maria, did you have another comment? I see a hands up.
There are a couple of questions that have just come in, Coletta. If I could just touch base on a couple of those questions.
You've got 1 minute.
I can make it fast. She knows I can be wordy. One of them is there an option for an ACM aligned treatment plan? Absolutely. Based on the configuration portion of the master treatment plan, you can absolutely configure this to any fields that may be relevant for the ACM aligned treatment plan. Another one was, how does it affect the billing or charge master? You can add this master treatment plan module within an encounter. So as Coletta mentioned, whether you're checking in the appointment or finalizing an encounter that this is part of, by finalizing that or checking in the appointment, you still have the ability to have that charge, that billing process take place. And then another one that came in was about the signing off with the initial treatment plan versus updates. By allowing the signature to be applied for any section that is updated, whether it is the initial or an update, that will satisfy that need for any accrediting organization. We also will be allowing in the future the ability for an overall signature to be applied for an initial or an update. So I think those covered some of those last questions I wanted to make sure to touch on.
Maria, thank you so much. Again, Peggy and Maria, thank you for attending. Just a reminder, if you want the Master Treatment Plan e-learning guide, send an email to clientservices@AZZLY.com. If you want to activate and be able to access this module, please, client services as well. If you're new to AZZLY and have more questions, go on our website. There's a great chat feature. It'll connect you to our sales team. Peggy mentioned that they've got a webinar that's going to be coming up. I encourage you all to get on their mailing list, look for it from Accreditation Guru. Always knowledgeable, always invaluable. Accreditation as well as AZZLY, we do use Eventbrite. Please, please, please get on our mailing list. We're excited to serve you, and thank you so much for attending today.